Hello, Bacho, and welcome. Today, we're jumping into a topic that's bread and butter for any clinician. I'm talking about local anesthetics. You're going to use this stuff every single day. So mastering this, it's not optional, it's absolutely crucial. Let's get started. All right, so here's our game plan. First, we'll nail down the basic funda, how these drugs actually work. Then we'll see the sequence of the blockade, what helps them, what stops them, what happens if they get into the whole system, and finally, we'll look at all the tools you'll have in your kit. Ready? Okay, first things first, the numbness funda. We need to understand, right at the very core, how we make a part of the body completely numb. How do we do it? I mean, think about it. How on earth do we tell one tiny nerve, hey, you, just stop sending pain signals? It's not magic, not at all. It's pure, beautiful pharmacology. We're basically intercepting a message before it even reaches the brain's headquarters. Let's see how we pull it off. Okay, here's the entire secret, Joe. Local anesthetics are like the strictest security guards you've ever seen. They go to the nerve cell membrane, find these little doors called voltage-gated sodium channels, and they just block them, shut them down. And if sodium can't wash through those doors, the nerve can't fire. It's that simple. No entry, no signal, no pain. Finish. Now, this is where it gets really, really interesting. When you give a local anesthetic, it's not like a switch that turns everything off at once. No. There's a very specific order, a predictable sequence to how the sensations disappear. And knowing this is key in the clinic. Right, listen up. This is a 5-star must-know exam question. Mark my words. The very first thing to go is pain. Why? Because those pain fibers are smaller. They're easier to block. After pain, the sense of temperature fades. Then goes touch. And the last man standing, the very last sensation to disappear, is deep pressure, because those nerve fibers are big and tough. So remember the order: pain, temperature, touch, pressure. Got it? Good. Okay, enough theory. Let's talk about the real world, the clinic. How do we make these drugs work even better? And why do they sometimes fail? Because believe me, you will have a patient in your chair one day and the block just won't work. You need to know why. The classic scenario, a patient with a big, swollen, infected tooth, absolutely screaming in pain. You give a perfect injection, textbook technique, and nothing happens. The patient is looking at you, still in agony. What is going on? Why did your perfect block fail? See, the infection creates a war zone. The tissue becomes acidic, a low pH environment. This traps the anesthetic drug outside the nerve. It can't even get in to do its job. And what else does inflammation do? It brings more blood flow, which is like a river that just washes your expensive anesthetic away before it can even work. It's a hostile environment for our drug. So, what's our counterattack? We bring in a helper, adrenaline. It's a vasoconstrictor. And look at the difference it makes. Adrenaline squeezes the local blood vessel shut. This traps the LA right where we want it, so the block gets stronger and lasts way longer. Plus, less blood flow means less bleeding. It's a win-win. But, and this is the biggest but of the day, listen to me carefully, adrenaline is powerful, and you must respect it. There is an absolute rule, one you can never, ever break. You do not use adrenaline for a ring block on a finger, a toe, the penis, or the pinna of the ear. These areas have end arteries, no backup blood supply. If you shut down the main vessel, the tissue will die. You will cause necrosis. So just don't do it, ever. So we call it local anesthesia, right? But the thing is, some of it always gets absorbed into the bloodstream. It's unavoidable. And when it starts traveling all over the body, well, that's when our local problem can become a systemic one. Let's see what that looks like. The first organ to complain is the brain. And you need to know the warning signs. The very first sign, the classic one, is numbness or tingling around the mouth, circumoral numbness. You must ask your patient about this. After that, things can escalate fast. Restlessness, muscle twitches, then full-blown seizures. And finally, everything shuts down. Unconsciousness and respiratory depression. After the brain, the heart is next in line. You see, local anesthetics are cardiac depressants. At toxic doses, they do all the things you don't want a heart to do. They slow it down, bradycardia. They drop the blood pressure, hypotension. They make the pump weaker. And they can trigger dangerous rhythms, arrhythmias, which can lead to complete cardiovascular collapse. This is serious stuff. And now, a special warning, a red flag, about one drug in particular, bupivacaine. My dear students, it's a fantastic drug. It lasts for a long time. We love it. But it is much more cardiotoxic than other LAs like lidocaine. You must have tremendous respect for this drug. That means always double-checking your dose, always aspirating your syringe, and always being vigilant. All right. We know the how and the why. Now let's talk about the what. Let's open up your clinical toolkit and look at the different ways you'll actually be using these drugs. Each technique has its own purpose. Okay, first up, the easiest one, surface anesthesia. You just apply the drug directly on the surface. Simple as that. We're talking about anesthetic eye drops, a throat spray before an endoscopy, or a numbing cream like Emla on the skin before you put in a cannula. Easy peasy. Next is infiltration. This is what most people think of when you say local. You take your syringe and you inject the drug right under the skin, all around the area you want to work on. You're just numbing up all those little nerve endings. Perfect for minor things like stitching up a cut. Now we get a bit more sophisticated with a nerve block. Here, we're not just numbing a little patch of skin. We're targeting the main nerve, the big highway that supplies an entire region. We inject around that nerve and boom, the entire area it supplies goes numb. Think about a dental block for jaw surgery or a brachial plexus block for an entire arm. That's a nerve block. And finally, the big guns, spinal and epidural anesthesia. We use these for major surgeries on the lower body. Now, the key difference between them is all about location, location, location. For a spinal, you go deep, into the subarachnoid space, right into the fluid around the spinal cord. For an epidural, you stop just outside that layer, in the epidural space. It's a game of millimeters. Just look at this table for a moment. Specifically, look at that last line. This, my friends, is clinical pharmacology at its most elegant. For a woman in labor, we can give a very, very dilute solution of bupivacaine in an epidural. At this tiny concentration, it blocks the small sensory fibers carrying pain, but it doesn't block the big motor fibers. So what's the result? The mother is comfortable, her pain is gone, but she can still move her legs and help with the delivery. It's absolutely brilliant. So, I'll leave you with this thought. Local anesthetics are a phenomenal tool. You'll depend on them every day. But as we've seen, they are not toys. They carry real risks. True mastery isn't just knowing how to give an injection. It's understanding the drug, anticipating the problems, and putting your patient's safety above everything else. It takes knowledge, it takes skill, and it takes constant vigilance. Don't ever forget that. Thank you.